Welcome back to another episode of HealthCap Weekly Wrap, where we bring you the latest updates, insights, and stories shaping the world of senior living care.
Yeah, and this week, we've got a really well rounded lineup. Starting with a closer look at a fast spreading COVID variant called Nimbus.
We're also diving into updated recommendations from PALTmed to help care teams reduce unnecessary treatments and promote safer practices.
Then we'll break down a successful deprescribing initiative out of New York that made a real difference in polypharmacy rates.
We'll look at a growing collaborative in Pennsylvania that's pairing nursing homes with nursing schools to bring age-friendly care to life.
MedPAC's proposed 5-star rating system overhaul is also on the agenda. Big changes could be coming to how quality is measured.
Plus, we've got a new study on how structured huddles can help teams respond better to serious reports of staff misconduct.
And we'll wrap up with CMS's latest fraud prevention stats and some important alerts about phishing scams targeting providers. Let's get started.
So let's talk about this new COVID variant, Nimbus.
Right? It's actually the NB.1.8.1 Omicron subvariant, and it's under World Health Organization monitoring. It's been spreading quickly in Asia and has started showing up in U.S. airport screening data.
It's making headlines not just because of how fast it spreads, but because of the symptoms.
Exactly. The most distinctive is a sharp, razor blade like sore throat. People describe it as more intense than anything they've had before. Plus, there are gastrointestinal symptoms nausea, diarrhea, abdominal discomfort.
That combination is rough. And in senior living, those symptoms might get missed or attributed to something else, especially in residents with communication challenges.
Right? Especially in folks with dementia or chronic GI issues. It's easy to overlook early signs.
Are we seeing hospitalizations go up?
Not significantly yet, and the variant doesn't seem to cause more severe illness than other strains in the JN.1 lineage.
That's good news, and vaccines still seem to help?
Yes, even though it's not a perfect match, being recently vaccinated still offers protection, particularly against serious outcomes.
So it's not panic mode, but it is something communities need to track, especially with summer gatherings happening.
Exactly. Keep an eye out for those unique symptoms, reinforce hygiene practices, and make sure boosters are up to date, especially for high-risk residents.
Let's move on to clinical care. PALTmed just released new Choosing Wisely recommendations.
They did, and these updates are really aimed at helping interdisciplinary teams work smarter. It's not just about stopping overuse, it's about building safer, more personalized care.
Give me an example.
Sure, things like not using sliding scale insulin for long term management in nursing home residents. It increases hypoglycemia risk without improving outcomes.
And I saw they also said to stop using aspirin for primary prevention in people over 70.
Right. Unless there's a strong clinical reason, the bleeding risk outweighs the benefits in most older adults.
That's something we still see in a lot of med lists.
Exactly. The other big one is minimizing anticholinergic burden. Don't combine meds like antihistamines, certain antidepressants, and bladder meds that all have cognitive side effects.
That's such a common polypharmacy trap.
Totally. And they even got into practical stuff, like recommending once daily or alternate day iron dosing for better absorption and fewer GI issues.
It sounds like this list could spark some really productive care plan conversations.
That's what it's for. These recommendations are built to be used during team huddles, med reviews, and quality audits. They help shift the focus from what are we doing to why are we still doing this?
And getting the whole care team on the same page is how you build safer systems.
Speaking of medications, that deprescribing initiative in New York showed some serious results.
Yeah, it was led by the United Hospital Fund, and it focused on safely reducing polypharmacy in 5 nursing homes using a structured tool.
1/3 of residents moved below the medication overload threshold, right?
That's right. And they also reduced high-risk prescriptions, things like sedatives, anticholinergics, and meds with unclear benefits for frail residents.
That's a big deal, especially considering how common polypharmacy is in our field.
Exactly. Older adults in nursing homes are often on 10, 12, even 15 medications. This program showed you can reduce that safely with the right supports.
Did they mention how staff responded?
Yes, nurses appreciated the reduced med burden. Fewer meds meant shorter passes, fewer side effects to monitor, and more time for actual care.
And from a family standpoint, deprescribing is often seen as a positive, especially when explained well.
Absolutely. When we say, we're removing meds that may no longer be helping, that builds trust.
So this isn't about cutting corners, it's about aligning meds with goals of care.
Exactly. And it's a great model for communities looking to strengthen their medication review process.
Let's switch to workforce development. Pennsylvania's doing something pretty inspiring,
Yeah, the Pennsylvania Teaching Nursing Home Collaborative is connecting nursing homes with nursing schools to elevate elder care education.
and they're using the 4Ms framework, right?
Exactly, medication, mentation, mobility, and what matters. It's part of the Age-Friendly Health Systems Initiative, and it's the backbone of this training.
That's such a smart way to build future ready staff by immersing them in real world settings from the start.
Right, in just the pilot, they trained 677 staff, had 510 students complete clinical rotations, and impacted almost 600 residents with age-friendly care.
That's a massive amount of exposure and a mindset shift for the students, too.
Yes, it's changing how nursing students view long-term care. Instead of seeing it as a fallback, they see it as a field with depth, complexity, and purpose.
And for the nursing homes, it's a chance to shape the next generation while getting fresh energy in the building.
Exactly, it's also scalable. Other states can adopt this model or partner with the collaborative as friends to access the resources.
We always talk about solving the staffing crisis. This feels like a real solution with long term impact.
Let's talk ratings. MedPAC wants to rework the 5-star quality rating system.
Yes, they say the current system doesn't accurately reflect true quality or resident experience and may unintentionally penalize communities serving higher risk populations.
So, what are they proposing?
A few things. One is reducing reliance on inspection results, which often reflect compliance more than care. They also want to include more resident centered metrics.
Like staffing stability or rehospitalization rates?
Exactly. And incorporating social determinants of health so the ratings reflect complexity, not just penalties.
That could really shift how quality is measured and funded.
Yes. And they're considering phasing out the STAR format altogether in favor of more detailed public reporting.
That might be harder for consumers to digest, but more useful for teams and regulators.
Totally. It could push communities to focus less on chasing stars and more on improving what really matters to residents.
It'll be interesting to see how this evolves and what tools communities will need to adapt.
There was also a new study on using huddles to respond to staff misconduct. What did that show?
This was a multi-site study involving 5 health systems that implemented structured huddles to respond to serious behavioral concerns.
So instead of just reporting and waiting, the leadership team meets quickly to assess the situation.
Exactly. They look at the context, review any documentation, and decide on next steps, whether that's coaching, investigation, or more formal action.
What kinds of incidents triggered these huddles?
Most commonly, reports of discrimination, hostile behavior, or sexual boundary concerns. Some involved suspected impairment or retaliation.
That's heavy stuff and often hard to talk about.
Right, but the structure helps. It creates a defined process and timeline so concerns don't fall through the cracks.
And I imagine staff feel more confident that they'll be heard and that leadership will act.
Exactly, it boosts transparency, builds trust, and creates accountability.
And in senior living, culture is everything. If we don't handle these issues well, it shows up in resident care too.
Absolutely. This is a model communities can adopt with minimal lift but meaningful impact.
Let's wrap with CMS's fraud prevention efforts. Some big numbers just came out.
Yeah, in just 6 months, they suspended over $1.3 billion in Medicare payments and flagged $1.1 billion in overpayments.
That's massive. And they referred over 180 cases to law enforcement.
Right. They also blocked $106 million in improper claims using automated edits. So prevention is working on the front end, too.
And now they're warning providers about phishing scams?
Yes, scammers are posing as CMS, sending fake audit requests via email or fax to collect sensitive data or money.
That's terrifying, especially in busy billing departments where those faxes just blend in.
Exactly. CMS is urging providers to verify any request directly with their Medicare contractor before responding.
This is a good time for communities to review internal protocols, especially around document handling and staff training.
Absolutely. Fraud risk isn't just about malicious billing, it's also about external threats and human error.
And staying compliant protects more than finances. It protects your reputation and the residents who rely on you.
Couldn't agree more.
That's going to do it for this week's HealthCap Weekly Wrap.
Thanks for joining us. We covered a lot today, from the latest COVID variant to cutting-edge care collaborations and CMS fraud alerts.
And every story had something in common: real, practical impact for senior living professionals.
Whether it's adjusting a medication routine, rethinking quality measures, or creating a safer team culture, it all comes back to how we care for residents.
If something we talked about today sparked a new idea or conversation in your community, good. That's the goal.
And if you want more details on any of these stories, you can find them all in the weekly roundup on Angie's blog at healthcapusa.com/Angie's blog.
We'll be back next week with more insights, updates, and stories that matter to the work you do every day.
Until then, take care and keep doing the work that makes a difference.